I think I'm a behaviorist at heart. And so here are the things you need to do to achieve what you've told me you want to do. And phones and or other technologies can help drive some of those behaviors for people.
Today's conversation is with somebody who has a truly unique view into the mental health care system and what it takes to improve it at scale. I sat down with Dr. Stephanie Eken, a triple board certified child psychiatrist and the chief medical officer at Acadia Healthcare, which delivers behavioral health care to hundreds of thousands of people across the country every year. Dr. Eken brings deep clinical expertise and systems level perspective. And in this episode, she shares how we can make mental health care more effective, more accessible, and more grounded in the real world. We cover why evidence-based care isn't always what gets delivered, how AI and ambient tech can support but not replace clinicians, what state fairs, schools, and churches have to do with early intervention, and why loneliness, stigma, and gender norms are still massive barriers to care. There's a lot to take away from this one. Let's get into it. Hello, and welcome to Neural Compass. I'm Mark Jacobstein, founding president of Jimini Health. I am really honored today to have with me Dr. Stephanie Eken. So Dr. Eken, not only an MD, but also an MBA and a triple board certified distinguished psychiatrist with more than 2 decades of experience in behavioral health. Dr. Eken is currently the chief medical officer at Acadia Healthcare, which for those of you who don't know is a leading or perhaps the leading behavioral mental health institution in the entire country. They have 250 facilities in 38 states providing care for hundreds of thousands of patients. We're going to get into that some more. Before this, Dr. Eken was the chief medical officer at Rogers Behavioral Health. And I think it's fair to say, given the roles at both Rogers and Acadia, probably very few people in the country, if any, know more about how to deliver care in scalable ways and how to operate and to deliver complex, both out and inpatient care in very, very diverse settings. So I'm so excited to have you here today.
Thank you.
Look forward to the conversation. So,
Thanks for having me.
Of course. So I thought I'd actually start with sort of how did you get here? Tell me a little bit about like the path, starting with like the interest in psychiatry and all the way through.
Well, I'm not the girl who wanted to be a doctor her whole life. I'm not somebody who wanted to do psychiatry my whole life either. And in fact, I come from a family where no one's really medical. So, but I, became interested in science throughout my, formative years in education, went to medical school. Honestly, I played a lot of sports, thought I was going to be an orthopedic surgeon. That was what was happening, early on. I've never quite understood this, the ex-jock orthopedic surgeon thing, but like that, I mean, I know it's a thing. I think you get exposed to orthopedic surgeons early, right? In your athletic career.
When they're setting the tibia. Yeah.
Right. Exactly. So, I dealt with some issues, really like the orthopedic surgeon that was part of, I played college basketball. And so, saw them and that just made sense in my head. They were interfacing with athletes too. And I, really identify as an athlete. So this is what was happening in my mind as I went off to medical school. It just changed over time for me by the people that I was exposed to. You always get incredible mentors, right, when you're going through these educational experiences. And I then switched pretty quickly from wanting to be an orthopedic surgeon because it just wasn't quite the practice setting that I was imagining for myself doing surgery in hospitals. It was really pediatrics that got me very interested. And you said I'm a triple board physician, so I'm pediatrics, adult psychiatry, and child psychiatry as my background. And it's funny, I was going through it. I was honestly imagining myself maybe doing some ICU care. But what I found myself doing repeatedly was interfacing with families a lot and talking about what was happening for their child, from the dynamics of it all, right? You have a child with cancer. What does that do to a family, to their siblings, to their parents? I mean, these are big shifts and changes. And so I had the opportunity to rotate with a child psychiatrist at the time when in medical school. And I was like, I really wish I could be a pediatrician and a child psychiatrist. It's this very interesting interface to me. And he's like, well, you can. There's a program where you can do that. And in fact, I'm one, but he did it the long way. And at that point in time, too, we were seeing a patient who had really significant obsessive compulsive disorder. They were pre-adolescent, essentially. They were about 11 years old. And their OCD was caused by strep. which is a common, right? A common bacteria that we see in kids that cause strep throat, other infections. And so that's like what really launched me between my interfaces with family and then my interfaces with how mind body interactions start happening with the brain. Like I was like, okay, I'm going to
That's
go do this
amazing.
triple dose.
I really want to dig in on that. We've had some other conversations with some of my other podcast guests about the incredibly intricate relationship, for example, between the immune system and the brain.
Right.
And so now I'm wondering about the channel between strep throat and OCD.
Right. So there is something called PANDAS, pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections. Now that is broad. There's another broader diagnosis now called PANS that encompasses other viruses, bacteria that may have the end result of being OCD and now even restrictive type eating issues. And so yes, we developed this like leaky brain barrier, right? And then these antibodies, they go attack certain parts of the brain. And it's actually, I mean, I don't think we don't have great research to tell us like how much this is happening. I don't think everyone who has OCD is walking around, right? Because they have a strep infection.
That's strep, but sure.
Yeah. Don't think that's the case, but there are these really unique acute onset presentations that are they're pretty impressive in how they present, really severe OCD, often with other symptoms as well, like children with very significant, what we would call flares, where they might have a lot of, anger or separation anxiety, or even difficulty with their handwriting. Like you could actually see neurologic signs sometimes changing. So very fascinating. And so this is how I launched into psychiatry.
Very
and in fact,
different than orthopedic surgery.
Yeah, yes, very different. And I functionally was a general pediatrician and a child psychiatrist out in the community for several years before I went into a broader system approach. And I think part of that for me was I love seeing individual patients. I love their families, but I kept always being drawn to like, okay, what is the bigger issue that might get the individual patient here in front of me? How do our systems impact health, right? How can I impact a broader population of people as I progress in my career? And so now, now I'm at Acadia, the, largest for-profit freestanding behavioral health company in the country, and really having an opportunity to do what I would say is population health from the behavioral health standpoint, which is exciting because it's a lot of impact.
I mean, and the pop health, it's so interesting. I mean, I think it's so important and wonderful that you had the experience of providing actual care and individualized care, because I always feel like pop health is sort of top down, individualized care is bottom up, and that the best solutions often arise from you need both perspectives. If you don't really understand what life is like for the clinician or for the patient and their families, or kind of the systems that sit underneath this and are producing the OCD, whether it's strep or something happening at the home or what have you, it's going to be very hard to design solutions. But so I'm curious about that then, sort of now tying this into kind of the work today. What is it that people don't understand about sort of real world, highly complex care at scale? What would you say are some of the most surprising things that you've learned in the time at Rogers and Acadia?
Well, I mean, I think it's interesting in general. Even I would say at the most personal level, my family members don't always understand how care is provided from a behavioral health standpoint in our country, right? How does one access care in behavioral health? What does it mean to be on an inpatient unit? Why do you go to one? I routinely, and it's the thing, I don't know that it surprises me, but it surprises me that it continues on, is the difficulty that people have navigating our behavioral healthcare system. Mm-hmm. And I feel like I'm this constant convener and navigator for folks. Even some of my closest friends are, they've been physicians now for decades, and they might be an OBGYN, they might be a pediatrician, and they, for their own patients, really need help navigating systems that are very difficult for our behavioral health folks. And when do they need that system, right? Like sometimes we wait longer to enter into the behavioral health space. So I think the surprising part is how much that continues to be true
Mm.
in today's world, really pervasive throughout my career. And then, well, I think many things have improved around stigma and getting care. It's still, I run into it on the daily. And it can be for those who have a substance use disorder. It can be for those who are suicidal. How do I talk to these people? What do I do? Um, but I think the remnants of that, like in a lot of our society, the younger ones are pushing us on this. I love it. They
Yeah,
talk
it's
openly about
interesting
it,
because
right?
I just had a conversation yesterday with an advocate who works in the space whose whole shtick is pulverizing the stigma and he's working. He's very public about his own battles with major depressive disorder and the things that got him better, and then working to, I think, particularly sort of with young men, where there are maybe real the stigma issues and around sort of old school machismo, like I can't reveal my feelings, let alone that I'm struggling, et cetera.
Right.
And but I will say, like, there's glimmers of hope. There are an awful lot of,
Absolutely.
from DeMar DeRozan to Selena Gomez to, it
Yes.
helps when people are talking about their own public battles. And so I'm curious if you're sort of feeling that. You mentioned that the young people are pushing here.
Yeah. I certainly do in my younger population. Frankly, sometimes they're more like it surprises me how open that they are.
Mm-hmm.
And you even have to talk about that a little bit. Like, what are the risk benefits to you individually? So it's incredible, I think, that people are using their platforms because it does open up a conversation that, frankly, just was not there publicly, earlier in my career. And I think it's different, though, by age. And I think the gender piece is important, too, as we think about that. The stereotypes that we put for you know, any gender out there starts
Yeah.
very early about what's okay. Even in today's world where, that's more fluid, there's still pretty hard stereotypes out there that people have to contend with.
Yeah, that doesn't surprise me to hear you say that. Well, and so just thinking about that in terms of like system dynamics, I mean, you're seeing hundreds of thousands, I guess millions of patients actually, in both in and outpatient settings, and the sort of navigation piece sounds like it's one of the really tricky bits. Can you talk about sort of how you think about that, systems that you've tried to implement? Because presumably you're a freestanding behavioral mental health organization, which means you're not providing primary care or oncology treatment, or you're not somebody's OBGYN if they're coming in for postpartum. You don't have the sort of continuum of care. So how do you think about that from a navigation perspective? Are there systems you're building, have built, et cetera, that you think are helpful?
Well, I think certainly there are partnerships that we have that we focus on quite a bit. With Acadia, we have over 20 joint venture partnerships, which is one way. I think we're trying to improve access for those who might show up to other health systems and they need help with on the behavioral health side, right? And getting people between what I would say the med surg side of the house versus the behavioral health. So that's one way I think Acadia is thinking about it. And then I do think that there's this constant partnership with, all kinds of organizations that are out in the community because they're really the front door for so many, right? Whether it's an organization, whether it's an individual provider. So we do a lot of work around these pieces to make it as easy as possible to come into our system. But even things have changed over my career, right? Now, you used to almost always have to come through an emergency room if you were coming into behavioral health to a hospital setting.
Right.
Now it's not just Acadia. I mean, there are other places doing this. Like you can walk into, right, to our facilities and get an assessment. So it's finding different ways for a community. I think locally, we always say I think about population health, but there is a local aspect to it. And so what organizations are active, whether they're religious organizations, whether they're school systems, how do you go in there and help? We actually partner with one organization that has a really broad representation in schools called the Jason Foundation. They do a lot around adolescent suicide. Incredible organization. And they go teach teachers and adolescents about identifying and helping people access care who are suicidal, who are in their schools. That is the way I think we get to a lot of people, is going where they are instead of asking them always to come to us, because it's already hard enough, right?
Yeah.
To say,
It's
come to us.
it's a really interesting thing because it's sort of it's pushing sort of the even sort of almost the diagnosis piece out into the community. Like it's allowing people to help self-diagnose and or a teacher to recognize a
Right.
child who's really struggling, et cetera, and maybe get them into care and into the system
Yeah.
sooner rather than later, which, you know, in particularly the adolescent suicide piece is sort of particularly, I live in a community in Palo Alto, which has a really serious problem with this.
Right.
And it's the
Right.
statistics on this are terrifying as somebody with young kids.
Yeah.
I'm very happy to hear that you've been able to sort of push this into earlier detection, as it were.
Yeah.
What sort of any organizations that you've worked with that have been sort of particularly successful with this?
Well, I did mention the Jason Foundation. I mean, I do think that they are incredible. They are, advocating and pushing legislation too to make sure we do have training for our schools. So I think they're an organization that I have, a lot of respect for. And then, there are other organizations that I think I've worked with throughout my career. There are places like NAMI, right, that do work in states and communities. I've had the opportunity, and they really get to know a local community and what is available. Interestingly, I mean, there's all kinds of partnerships that can be so successful, even from government, from state health agencies, right? And what are the programs that they have out there? Some of the things that we've done more recently in the midst of the opioid epidemic, right, is how do you distribute free Narcan for overdose, and then also have the ability to have conversations with people, convene people as they come and, get free Narcan. So I think, like, just use your creative mind. There's so many different ways.
That is a wonderfully creative idea. I mean, I love more Narcan can save an awful lot of lives, but yes, it is also an excuse to have a conversation with somebody about whether or not they want and need some help.
And even doing them within community fairs. I'll do my public service announcement here. I feel like as a pediatrician is like, I always say to parents, it's great for us to go to community fairs and give out Narcan, have a conversation with a parent, because you never know what's coming into your house. It should be part of your first aid kit now. And so it just, all these different ways, get you to talk to people about what's happening in their community. I've done a lot in my career in terms of, just speaking in different types of facilities in order to get the word out there about what's possible. So as I mentioned before, in some communities, religious organizations or churches can be incredible ways to have those conversations. I've gone to schools and talked. Sometimes I tease, I'll go anywhere and talk at state fair, doesn't matter. Like, put me out there. I'll talk about behavioral health and adolescent suicide crisis or whatnot.
Yeah, that's amazing. So first of all, thank you for the work. And it was really, this sort of ties into a question I was going to ask you, which, I think about the challenges of mental and behavioral health as sort of twin problems of efficacy and access. We don't have enough access because there are not enough therapists. There are not enough psychiatrists. There are not enough beds. There's not enough. And also we have interventions and treatments that vary in their efficacy, right? And it depends on which condition you're talking about. But I don't think anybody feels like we're done with coming up with the things we need for everything from serious mental illness to garden variety anxiety and depression, and everything in between. And so, but one of the things I think most interesting about the conversation with you is, like, I read a lot of studies, and this was in the New England Journal or what, and it's like very controlled situations.
Right.
And then there's like the real world. And I used to work in oncology, and the difference between the care that somebody received at Dana-Farber or at MD Anderson in a clinical trial and what was happening in the community was often vast. And not because the community oncologists weren't terrific at their jobs or working very hard, but because the reality of their practice was they saw people with every tumor type from phase 1 to phase 4, and half of what they were doing was practicing primary care medicine to help keep their cancer patients alive from all the other things. And it was very different. I'm curious, Acadia is like, that's real world. This is like real world, lots and lots of patients, many different states, many different scenarios. what are some of the most like unexpected challenges that you've bumped into versus because you have a career, we'll talk about this later. You've done research. Like there was a career before this that was, I think, probably a very different setting.
Yes.
Talk about kind of
Let's say I've been on different ends of the spectrum,
yeah,
right? Not,
right.
I wasn't a big academic, but I did very specialized treatment. And frankly, most of the clinical care I've provided in my career has been a pretty specialized version
And
of
a lot of work in
psychiatry.
OCD
Yes.
yeah.
A lot of work in pediatric OCD
Yeah.
specifically. I always tease, I want to get them before they're even adolescents because like I want to get them back on their developmental trajectory. And then a lot of work in pediatric eating disorders. So that's where I've
Hmm.
spent a lot of my career clinically.
Yeah.
And now here I am at Acadia, right? Providing, helping oversee the provision of care to people of every diagnostic category one can imagine. And it was an adjustment, but it's a real privilege is how I see it too, because there are clinical standards. I think that's the one thing, that in behavioral health, sometimes we don't hold ourselves as accountable to. You're not going to have a protocol like you do for cancer, right? For a particular, type of cancer. But we have to give compelling reasons for people to come into treatment and to be on clinical pathways. And I think about that a lot at Acadia. I use the example oftentimes of if you went in with a stroke somewhere to an
Yeah.
ER, there's like a pathway, right? And they're going to tell you, okay, you're here in the ER. This is what needs to happen. You might be admitted to the hospital. After that, you're probably going to need some kind of like maybe inpatient rehab. Maybe you'll need outpatient. And there's this pathway that we talk about to getting well. And that's something I talk about a lot at Acadia because we do have different levels of care as well that we are privileged to treat people in. But also, what are outcomes for that? It
Mm-hmm.
doesn't matter what diagnostic category, right? What are outcomes for that? And what is the reason I am asking you, individual patients, to follow a clinical pathway? What's the compelling reason? What does our research show us? And what we can do is we can take our data at Acadia and say, we're doing really well with these populations. Maybe here's a population that one of our facilities is doing incredibly well with. Okay, let's go learn from them. We have a lot of experts. That's kind of the fun thing, right? Is when you have so many treatment facilities, you end up with these incredible people. And I'm like, I don't know why they're getting people, so much better in that, people are doing well and this group is doing really well. Let's go be curious about that. So that's been an opportunity that we've had. But then for me with Acadia too, is to go with our joint venture partners who may have an academic or research background and say like, in general, we are seeing this in our population in Acadia. When I look at the literature, there's issues here too. You guys are looking to solve this. How can we bring all parties together and think about this? Are there new technologies out there? Are there new drugs coming out? Are there different ways we can apply therapy, for these patient groups? So this is what, my clinical and nursing leaders, and we all spend time of like, how do we truly provide care in very small periods of time for those in our acute facilities, those who spend maybe longer time with us in residential and go out into the community, and what does well look like? And how should we be setting the bar for what well
Yeah.
looks like, not just limping by,
I love this because Acadia has this sort of unique opportunity at the intersection of what I call real world data meets kind of like clinical protocols. Your ability to actually see enough patients to have a sense of like what's working and what isn't.
Correct.
Not in a Nature paper, New England Journal paper
No.
setting, but like in a like this is the reality of providing care to lots and lots of people. I think is unparalleled. I'm starting in oncology. There's a group. Sarah Cannon was a hospital group that provided a lot of care to a lot of people, and it was community based, but also had this sort of academic bent. And they wrote a lot of interesting and important papers that were sort of at the intersection of deep research meets real world care. And so. One of the things also you talk about protocols. I was struck by I was looking at some of your research work that you'd done earlier in your career, and a lot of it, as you mentioned, in OCD. And one of the things that you called out in one of your papers was that there were a lot of therapists who did not, for example, use exposure therapy, even though it was demonstrated to be effective in various scenarios. And there were reasons for this. And I think you talked about this in the paper. But one of the things that's always been interesting to me is I'm an outsider. I'm not a clinician.
Hmm.
Right? I'm married to a physician scientist, but I am not a physician clinician in any way. So I'm always struck by the fact that there are protocols that are there's the things we're supposed to do, right? If you
Right.
have EGFR driven non-small cell lung cancer, you're supposed to get osimertinib. And like 40% of patients don't, right? And right. And similarly, as you discuss in your paper, with at least certain types of OCD, we know exposure therapy is very, very effective, and yet it doesn't happen. And this is not unique to mental and behavioral health, obviously, but I suspect that the problem might even be more challenging because of the kind of squishier, more subjective nature than like, here's a tumor, it's melanoma.
Correct.
Um, and so, as a CMO with tens of thousands of caregivers who work for you,
Right.
how do you think about like, how do we implement protocols? How do you make it happen?
I mean, this is what I'm working with my team on a daily basis, thinking about, right? Like, it's almost like implementation science. And I
Yeah.
am, like I said, I'm not a big researcher, but how do we take best practices and, monitor what's happening? And to be honest, there's a technology I think is going to play a larger role in this. So one, I just want to say, since our new CEO, he's been here for about 3 years now, Chris Hunter, he's big into like modernizing behavioral health, which is fantastic, and has brought in innovations. But, with AI and ambient, listening products, I think we have an opportunity for around fidelity monitoring,
Mm-hmm.
and educating. This is not to say like, oh, I gotcha, you didn't do the thing that you're supposed to do. That's the evidence-based intervention. It's really to say, you know, are you using evidence-based protocols? If not, how can we support you? I think the thing too that's like very complicated in behavioral health. So it's like I don't want to be reductionistic because somebody doesn't present to me with depression only. Like that just doesn't happen anymore,
Right.
right?
Right.
Like I tease about I have some colleagues that I've worked with a lot in my career around pediatric OCD, and some of them are incredible researchers. And they're like, yeah, we don't take anybody in our studies who has Tourette's or like
I know
ADHD.
the I&E criteria. So the inclusion exclusion criteria in like every clinical study I've ever seen is like,
I know.
who are these
Yeah.
people?
I
Right.
know. I
Yeah.
like, I don't have these patients. Who are these
Yeah.
patients? So, but I love talking to them and working with them to say, here's what it's like in the real world. Here's what we're seeing. And now what I love is like a lot of the researchers want to come in and look at your data of these real world patients and say, oh, what can we learn from that? Instead of the other way of them telling me always the thing that I should be doing. But I do think, we do a lot of broad education and we think about what we're going to support from an evidence-based standpoint, always trying to, make sure we have those guardrails. And you have electronic health records. They don't guide all those things, but they certainly can give us, thinking about what
Clinical
clinical
decision
standards are.
support out of the health record is something that, again, as somebody I came from the tech world. I spent 25 years in sort of pure tech,
Yeah.
and then I moved into healthcare. And it was about a decade ago. I was very surprised to see, in general, because healthcare is full of extremely well educated, highly paid people, right? Like, and you're
Yeah.
like, okay, you're going to be up on all the latest and greatest, and typically not. And so things
Typically
like
not.
typically not decision support embedded inside of your EHR that would tell you,
Right.
you're the doc, make the call, but here's what the NCCN guidelines say for a cancer
Right.
patient of this sort, or here's
Right.
here's how one should maybe think about uh, OCD and this
Right.
SSRI or what
Dosing,
have
their
you.
SSRI, right? All
Right.
those things.
Yeah.
Yes.
So is that something that you guys are implementing, or you're thinking about implementing, or
Yeah,
takes? I mean, I know
we're
it's
really
hard.
just looking to, right. That is hard. But here's one thing I believe. I'm going to talk about physicians specifically, just
Yeah.
because like
Please.
I know that I am one. Like I know them. I think about their well being a lot. I've done a lot of work in that space as well as EHR. Is It is a little bit funny when you go out into practice, depending on where you go. You've been benchmarked and graded your entire life up until that point. And then a lot of people will be like, well, the physicians don't want to know this data. And I'm like, I disagree with that. Many of us do want to know, like, how are we doing? How are our patients doing
Yeah.
as a whole? right? And so giving them that data and making it easily consumable for them, there's different ways this is happening in healthcare, but I think, physicians often deeply desire to know how their patients as a population in a diagnostic category, like how am I doing as a doctor? Are
Yeah.
they getting better? And not in the ways that feels like penalized with around, like payers and regulatory that get doctors kind of wound up at times, but truly, am I
Yeah.
being a good doctor?
Well, and it
So,
encourages good behavior. I will tell you. So there's a old Silicon Valley company called O Power that
okay.
their shtick was they kind of showed you how much energy you were consuming as a right, and then they showed you how everybody else on your block was doing, and you're like, oh, I guess I'm using more energy than my neighbors with
Yeah.
a comparable sized house. Maybe I should put in some insulation. And like it was incredible how well and O-Power was implemented by the utilities, which interestingly wanted you to use less energy. I never quite understood I'm not sure I understood the economics there. I guess actually the grid was strained. I'm not sure. Anyways, it was amazing. Human beings are so, in some ways, so easily manipulated with like, right, a few incentives. I suspect that you're right. Like even just like, hey, here's how you're doing can push people in the right direction.
Right. Right. How are you doing compared to your peers? How are you doing with this population? So I think that's important information. And then from the therapist side, there are technologies out there now that with ambient listening products,
Yeah.
right, can come in and say, you spent this much time doing an evidence-based intervention. And frankly, there are people, coming out of school that may or may not have access to as much supervision as they desire, depending on their
Right.
community. And what an incredible tool, I feel like, to say,
Yeah.
how am I doing? I think I'm doing this, but like, here's actually technology that can show me holistically per session or broadly how I'm doing.
I'm so happy to hear you say that because I've been interested in this for at least 10 or 15 years, but only in the last 2 or 3 since we sort of had the LLM moment has the technology sort of arrived at a place where the ability to provide what I think of as like continued coaching, continued teaching for somebody's career, whether you're a therapist or psychiatrist or pick any other knowledge worker job, where, to use your phrase, ambient listening combined with a good AI can provide you feedback. I mean, I stopped after undergrad. I haven't been to school in 35 years, 34 years, and it'd be nice to get feedback on how am I doing. Now, I understand there's a big brother piece here that is a little bit tricky for the caregivers, but I think that's solvable.
Right. I mean, I think if you have a culture of trust and respect that's within your organization, that feels like a very different tool, right? Than if it's an I gotcha moment and you
Right.
didn't.
I'm listening and
Right.
you took 2 minutes extra on the bathroom break. Like, no,
Right.
like,
Right.
yeah.
To me, this is just a way to support and I mean, I'm going to date myself here, but back when I was learning to do therapy, right? There was the two-way mirror where they were watching me, or the one-way mirror, depending on right? And they were listening, and I would get a phone call from the other side and say, like, have you thought about doing this, Dr. Eken? And so, which is a little bit intrusive, right? And it's like with the patient and
If you
and
think
you're
about like what's happening in a teaching hospital when a student is rounding, right? They're like, there's the attending and there's the med student and everybody's learning, right? So it's an extension of the human capabilities that I think we already have. I mean, this leads into a question I was going to ask you about is as you think about innovation and what's happening specifically, I suppose, with AI, but also via mobile devices. I mean, there's all kinds of amazing technical advances in med devices.
Right.
How do you think about that for, pop health scale? And what are the most exciting things for you as you look to the future here with Acadia?
I mean, from a pop health, it's truly like access to some type of evidence-based treatment, right? I mean, with different technologies that are coming out there, even, there are these like FDA approved technology interventions you can do now for therapy, right? That you can prescribe now to patients and it's going to walk them through a certain path. It gives people options, right? Not everybody's has access or is going to go in and talk face to face to someone. It gives different learners different options. So I think from just how do I even interface with behavioral health treatment in any way, it opens up a world of possibility. Opening up that world of possibility also brings a lot of concern from people. I know too, of like, what is that? What are our safeguards in there?
Right.
But we have to be moving those together, right? Like being responsible and increasing access. To me, that's the population health piece. And then frankly, I think even at the individual patient level, as they can identify more and be educated on what's going on with them, then they might even access more beyond the particular technology that's in front of them. And it opens them up to the possibility of meeting maybe with an expert that would put them down a different path, perhaps to become well.
Yeah. It's interesting. I think the continuum of care piece is really interesting too, because there are certain types of medical interventions where, if you have strep, to go back to strep, you take amoxicillin and hopefully you're better, right? There are many other things. I mean, we all will struggle with our minds for our entire lives. Even people who do not have serious mental illness, like I always think of this as like anxiety, for example, is a feature, not a bug. It's a feature, not a bug of natural selection, right? It kept us alive on the savannas. It's really useful. If you have too much of it, it can be very destructive and challenging. And so we have skills that we want to learn. And I think that's true for anyone, diagnosed, anxious or not, right? And even if you go through, say, intensive inpatient for something and you come out the other side and you're doing much better, you still got the rest of your life to live. And having tools that you can take with you, I think will probably be very, very important.
Well, portability, of the therapeutic skills that we're teaching is incredibly important to me. But now you combine that with technology that one can keep you perhaps maybe, on track. Like we're all doing measurement-based care to ourselves. I say that. I mean, I'm sitting here with two devices. I have on an Apple Watch and a Whoop.
How many steps today?
Right. And so we look at that and we go, oh, I'm not where I usually am today. What am I going to go do about that in the moment? I actually think about like CBT or other evidence-based therapeutic skills. Like this is how we should think about them. What are we teaching them that they can use outside of us? Because if you're dependent on me, it's like I'd be a very bad pediatrician if someone with asthma was coming into my office every time they had asthma symptoms, right? If I didn't have a plan for them of how to deal.
Right. Here's an inhaler. Let's avoid dust. Right.
Yes.
Yeah.
Right. What are all the environmental and other factors we can do? Same thing as it. I think about that very same way as a child psychiatrist. What am I teaching you or what am I providing you with skills inside the office that are translatable? And here's now, okay, you're feeling anxious. Here's what you do. Here's the escalation steps if you need to get to. But how technology can help particularly I think about our younger generation who's like constantly tied to their phone, which has its own downside.
Well, it's the cause of and cure for all of life's problems. There's an old Homer Simpson joke about that. Like I think he says alcohol is a cause of and cure for all of life's problems. But I think about this is the problem for young people, right? It's a dopamine machine in your pocket.
Right. But it's not going away.
Nope.
That ship has sailed. Now, can we put parameters around it? Yes, but that's where you have to talk with parents. But it can also be the source of great things. I always say, if the tool is used correctly, it's a great tool. So you think about how phones have apps and different things of how you can interface, and they can truly, my whole goal is for them to function, right? Yeah. And so I think I'm a behaviorist at heart. And so here are the things you need to do to achieve what you've told me you want to do.
Yep.
And phones and or other technologies can help drive some of those behaviors for people.
100% agree. And a lot of young people are, for better or for worse, they are more comfortable sometimes with technology than they are with humans. And you have to bring the medicine to where the patients are, as it were. This is to go back to your point earlier about the outreach in schools and in churches and their community groups. So fascinating. Well, Dr. Eken, this has been such a great, wonderful, wide-ranging conversation, and we covered so much. I have a whole other list of other questions. We'll have to set up. We'll set up a second interview for you. Yeah. But really appreciate the time today, and I will leave with just one last question for you, which is anything that you have read, watched, consumed. It could be a book, a podcast, a TV show, or whatever that you found sort of particularly interesting and compelling, kind of vis-a-vis the stuff we're talking about today, the intersection of mental health and emerging technologies and sort of the future of the mind.
I'm trying to think of the name of the show that I recently watched. It was it's quite, I mean, it's been popular. It's been all over the news about the boy in
Oh,
England
yes.
who,
Uh,
yeah.
I want to say adolescent.
Yes, it was, yeah.
I can't watch it. Everybody's told me like it's so good. It's and like I have a
It's
I have a 9-year-old.
distressing.
I can't watch
Yeah.
it.
So, I mean, it made me think about loneliness a lot.
Mm,
And I mean, we've heard the Surgeon General say that, loneliness is an epidemic, one of our previous Surgeon
yeah.
Generals. And it is that interface with like technology and what they are seeing and being exposed to online, and how parents are all, I mean, I sort of, take the stance that people are out there doing the very best that they know at any given time. And, depending on the parent, they may or may not be as involved with like seeing what their child is being exposed to. And that show just really, I don't know, it did make me contemplate so much of like, there's this whole other life that's happening online. And the feelings that it can evoke. And if somebody doesn't have a trusted adult,
Mm,
it doesn't even matter if it's their parents, frankly, like a trusted adult to go have those conversations with them, particularly for boys, as we were talking about earlier in the show, right? What are the stereotypes that they're being exposed to already that prevent them from that?
right.
But that show, it is a really good show, but it is a very upsetting show, and some commentary on, some areas where I think we have to do better as a society around stereotypes, around addressing loneliness much more
Mm.
on the nose than we do.
And the vulnerability that
Right.
loneliness creates. Yeah.
Right.
Interesting. Well, that was actually an amazing answer, considering you didn't have one. So,
Yeah.
thank you again. Really enjoyed the conversation, and I look forward to more.
Yeah, sounds great. It was really nice to meet you.
Thanks for listening to Neural Compass, the Jiminy podcast. If today's conversation sparked something for you, follow us at Instagram, YouTube, or LinkedIn, or explore more at jiminihealth.com. At Jiminy, we're building the future of mental health care with effective, safe, AI-enabled continuous care. See you next time.